Okay, and welcome to the Davies Use Case webinar being presented by Children's Hospital Colorado on reducing the use of unnecessary CTs for appendicitis. This is a Davies Award-winning use case for the value of health IT, and my name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes the outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes, resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker from Children's Hospital Colorado, Dr. Lalit Bajaj. Dr. Bajaj, I will turn the presentation over to you.
Thank you, everyone. And I'm honored to present our program entitled Improving the Care of Patients with Suspected Appendicitis. My name is Lalit Bajaj. I'm a pediatric emergency medicine attending at the Children's Hospital Colorado, as well as the medical director of clinical effectiveness. Abdominal pain is a frequent complaint seen in pediatric emergency departments across the world. Nearly 2,000 patients present to our system every year with abdominal pain and suspicion for appendicitis. A third of those patients will present with appendiceal perforation, which is higher in children with Medicaid. In 2013, the National Surgery Quality Improvement Program presented data on the comparative use of CT scan amongst children's hospitals. Children's Hospital Colorado, which is outlined in the yellow oval, was found to be a high outlier in the use of CAT scan in the evaluation of abdominal pain and subsequent appendicitis in children. This data was corroborated by the Children's Hospital Association Pediatric Health Information System, or PHIS, data, which again showed us to be a high outlier, with approximately 41% of patients going to the operating room with appendicitis having a CT scan done prior to their operating room visit. We worked to characterize that data locally in order for us to better understand where the utilization was occurring. We have a system that includes the main campus, otherwise known as the Anschutz campus, as well as a system called the Network of Care, which includes outlying emergency departments and urgent cares that we staff. We found that the patients presenting to the Network of Care were demonstrating a very high rate of CT scan use. Our project aim was to reduce unnecessary imaging in patients undergoing appendectomy across the system to less than or equal to 20%, with no change in negative or missed appendicitis rates. We entitled our project the Imaging Gently Improvement Project, which consisted of a multidisciplinary governance team including representatives from our surgical department, radiology department, emergency department, and urgent cares, as well as members from our process improvement team, as well as members of our data team. We embarked to internally collect data from our Epic Clarity data warehouse, as well as creating real-time data dashboards. We performed extensive process mapping, time series studies, and an assessment and revision of our clinical care pathway. This is an example of a process map showing patients arriving into the emergency department and being evaluated for suspected appendicitis. The blue ovals represent areas where which we found we could integrate some tools in order to help patients be risk stratified, as well as some tools for the provider to help efficiently order the appropriate tests and procedures. In addition, we found opportunities to improve our data, especially our radiology readings, which I will go through further in just a moment. These time series studies were found to be very important in identifying areas of opportunity for which we could use the information systems to improve the care. Through our multidisciplinary governance group, we identified the following interventions to decrease unnecessary CT use. We created standard order sets. We revised our clinical care pathway and included pathway-specific instructions for our outlying network of care sites. We integrated an Alvarado score, which is a risk stratifying score, into our electronic health record. This score has been validated to help tier patients for risk of appendicitis. We developed a radiology template that allowed the radiologists to report standard information when interpreting the ultrasounds or CT scans for appendicitis, and we changed the language from positive or negative to high probability or low probability. We created expectations for timely consult from our surgical colleagues. We worked to increase site-specific ultrasound availability. And we also instituted a process by which the emergency department could not order a CT scan until the patient was discussed with the surgical team. Our order sets are easily accessible in the electronic health record, and the acute appendicitis order set here is highlighted. When that is opened, it prompts the provider to order the appropriate tests, as well as has a link to the appendicitis clinical care pathway. That pathway can be brought up directly into the Epic workflow to allow providers to see the standard pathway for which the patient should be evaluated. There's also a reminder to use the decision support tab to complete the Alvarado score. The Alvarado score is shown here on the left. It is a series of radio buttons that allow the provider to easily click on the appropriate historical elements. This also includes a laboratory value which will auto-populate within the Alvarado score if it has been obtained during the visit. The order for the imaging also includes a hard stop for the provider to place their subjective Alvarado score if they have not used the calculator. We found this to be important as many experienced providers were calculating this risk easily in their head since this complaint is so frequent. Our radiology readings were analyzed as part of this project, and prior to the institution of our template, we found that there was no consistent way of reading ultrasounds or CT scans for appendicitis. These are some of the examples of readings that we found in the electronic health record. As one can see, there's quite a bit of variation, and it's difficult to incorporate these findings into the overall care of the patient when they are not consistently reported. This is an example of the radiology template after it had been redesigned. And as you can see, it asks the radiologist to document whether they visualize the appendix, the maximum diameter, and then other findings that can be suggestive of appendicitis, such as the presence of an appendicolith or other secondary findings that you can see. We then ask for the radiologist to make a determination if this is a high probability, low probability, or an equivocal study. This allows the radiologist to incorporate all the findings into their conclusion. This is an example of how the radiology template would be reported on a patient that looks like they have a high probability of having acute appendicitis. A real-time data dashboard was developed to monitor progress within this quality improvement project. This process was performed by our data analysts in conjunction with our enterprise data warehouse team, where the data could be extracted and then visualized using the Tableau software. It also allowed us to filter this data on a variety of different other data elements that you can see on the right. This turned out to be a very important aspect of our project, allowing the quality improvement teams to monitor progress closely. We evaluated our ultrasound availability at all of our sites. At our main site, main hospital, ultrasound was available 24 hours a day, 7 days a week. In response to our high utilization of CAT scan and the satellite sites, we looked at the ultrasound availability and staffing. Traditionally, we staffed from 8 to 5 p.m., and these were primarily utilized for scheduled ultrasounds. Those hours were expanded to include on-site techs available until 8:30 p.m., and then after 8:30 p.m., the tech was available on call until the next morning. The emergency department and urgent care options included calling the ultrasound tech in for a patient with concern or observing the patient overnight and having that ultrasound done in the morning if it was still required. Similar to the main emergency department process, the satellite practitioner was required to speak to the on-call surgeon prior to obtaining a CT scan. This is a P chart which demonstrates the percent of patients receiving a CT scan prior to going to the operating room for diagnosis of appendicitis. And as you can see, our rates in the 2013 and 2014 era were close to that 40% that the external data was demonstrating. As the project was initiated in the fall of 2014, we began discussing the project with the ED staff, which likely resulted in a decrease in use as this pathway was about to be rolled out. I think this demonstrates the power of the conversation in looking at utilization. We subsequently implemented the pathway order set, increased ultrasound availability, and then instituted the radiology template. And then we quickly saw dramatic decreases in our use of CT scan and found this to be sustained over the subsequent 2.5 years that this data demonstrates. It was important for us to evaluate balancing measures in this process. It was clear from our emergency department providers that they were concerned they may miss the diagnosis if the CT scan were not to be performed. And our surgeons were concerned that they would take more patients to the operating room who were subsequently found to have a normal appendix. And as you can see on the left, the missed appendicitis rate with one particular outlier remained consistent over the time period of the interventions at around 3.5%. And our negative appendectomy rate, while being a strong marker of quality, remained around 4%, which is consistent with national benchmarks. Therefore, we were able to decrease our utilization of CT scan through multiple PDSA cycles, resulting in our now consistent rate of around 7%. When we looked externally at our pediatric health information system data, it appears to correlate that with our internal data, which is reassuring for us from an external validity aspect. We've looked at our financial outcomes within this population as well as the larger population, which I will just demonstrate in a moment. We found that the decrease in the number and percent of CTs certainly decreased the charges for CT scan dramatically. And consequently, our ultrasound charges did not dramatically increase. But we have a larger population of suspected appendicitis that we looked at to get a better idea of our overall utilization. And our proportion of patients receiving a CT scan in that overall population also dramatically declined. And when we look at the CT charges, we were able to decrease those by about $1.5 million from 2017 to 2014 per year, while our ultrasound charges remain relatively stable. Children are exquisitely sensitive to radiation as they have growing bodies, especially growing endocrine organs. What we found was we are doing about 300 fewer CTs per year than when we were at our peak in 2013-2014. Each CT scan is equivalent to an extra year of background radiation living in the Denver-Boulder altitude. This decrease of 300 less years of excess radiation is important for us as a safety measure in the appropriate care of children. I think it's important to comment that the amplitude of use of the CT scan significantly narrowed in our post-intervention time period, which suggests that our practice has now become hardwired. Designing and implementing the appropriate technology solutions was found to really drive improvement. We now have risk stratification, the Alvarado score, embedded in the workflow. The radiology template is used over 99% of the time. And we have transparent and real-time data contributing to provider engagement, and it really supported our rapid improvement. Our communication between emergency medicine and surgical providers was critical to the success of this program. Surgical consults and inputs have remained timely and reliable. We have seen sustained results, and our clinical effectiveness team is monitoring these outcomes consistently, and the process is now in control with limited variation. And this has now become the culture of care within our system. We learned many lessons throughout this project, including the value of the multidisciplinary team that combines clinical content, expertise, process improvement, and analytics expertise, which was all found to be essential to our success. We found great success in demonstrating our incremental improvements as the project went on, and analyzing our balancing measures was crucial to avoid the concerns that were brought up about avoiding CAT scan and avoiding the disengagement that can occur if balancing measures start to creep up. We also learned that sometimes decreasing utilization also decreases revenue, and that it's important to engage your finance team early on to project the impacts so that they can plan for them. In conclusion, we were able to dramatically reduce the utilization of CT scan in the evaluation of suspected appendicitis as well as confirmed appendicitis. Embedding our information technology tools into the workflow, in addition to our collaborations between all services, resulted in our sustainable improvement. Our charge and cost savings have been substantial, and we are now avoiding high doses of radiation, improving the safety of this process. And we believe that this represents a reproducible model for other institutions like ours. Next steps include continued review of the data on a monthly basis and ensuring sustainability. We routinely report our results to our Quality, Safety, and Experience Committee of our Board of Directors, and we are doing ongoing analysis of the data to best understand diagnostic safety and reasoning within this population so that we can better understand those patients that are missed as well as those patients that go on to have a negative appendectomy. Thank you very much for having us present our project.
Well, thank you, Dr. Bajaj, for joining us today for this recording. I would like to remind folks where to go find more Davies use case webinars and other information on how to apply for Davies. That information can be found at hims.org/Davies. Again, hims.org/Davies. Thank you very much.